that's why my sonographers picked them all up in the first semester. In the ISIOG guidelines, the 5-chamber view is not part of the ISIOG screening guidelines in the first semester. The ISIOG guidelines only include a 4-chamber view of heart and a 3-vessel tracheal view. Does not include a 5-chamber view. So I've already spoken about the setup. You can take a picture of that. That's the setup that I use in examining every baby. And for every baby that comes through our practice in the first semester of pregnancy, we take a split image showing the 3-vessel tracheal view and the 4-chamber view side by side, so we understand the relationship of the great vessel. If you do that single picture for every single baby at 13 weeks, you will pick up the majority of major abnormalities we've spoken about today. So this is just the facts and figures about the markers. I'm going to skip through these in the interest of time and just show you examples. So this is the baby with the stomach on the left-hand side, and the heart is rotating. So the axis of the heart is rotating. Left axis deviation. Another case with the heart with left axis deviation in a baby with tetralogy fallow. So these are very useful markers in the first trimester. Then there's the Y side, or the Y configuration. And this is what a Y configuration looks like. And these are all babies with tetralogy fallow with a Y configuration here, 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 here. So again, very powerful marker. And then there's a question mark configuration. So when you look at the left ventricular outward tract coming out, you find in the situation where there's a left descending aorta, not the right, but the left descending aorta, you find this configuration where the aorta sweeps to the right and then back to the left of the trachea. And this is referred to as the question mark sign. And you see this in an LVOT view, very powerful as well in the first trimester of pregnancy. So, increased nuchal translucency, left axis deviation, Y configuration, question mark configuration, tricuspid valve regurgitation, and ductal venosus reverse A-wave. These are all powerful markers in the first trimester of pregnancy for tetralogy fallow. And if you see any single one of these markers in the first trimester of pregnancy, the next step is then to go. So this is a baby who I saw very recently. She comes in looking at the scan, and the sonographer, Simon, the 4-chamber looks okay, descending aorta left is fine, but when I look at the 3-vessel tracheal view, she has a Y configuration. I say, yes, I agree. I said, did you do the pulse Doppler? She said, when I looked at the pulse Doppler, I could see there was alicing across the pulmonary valve, and the velocities were around 50 centimeters a second. Remember, the PRF, you set it to 25 to 35. And I compare it to the aorta, and I see there's a discordance between the aorta and the pulmonary artery, and I can hear the difference. I then use slow flow, and I use 5-chamber. I'm not screening anymore, I'm doing a dedicated fetal echo. Using slow flow technology with balanced set low, I can see the aorta sitting astride into ventricular septum. And then I use slow flow monochrome, not color, because I don't want directional information. I see that this is the descending aorta, and now I see the question mark sign. So I have all these markers are coming together in this baby. I then look at power Doppler, I see the question mark in the power Doppler, and on slow flow I see the trouser leg appearance, and then I do a stick. I ask the patient to hold her breath for 15 seconds. I acquire from the neck down to the stomach in 15 seconds as she's holding her breath, and I do a force D stick acquisition. Once I've got the stick acquisition, I now have a beautiful view of this heart, which this is 1 centimeter here, and here to here is 1 centimeter, 7 millimeters across. Normal 4-chamber, I can see the aorta sitting astride, I can see the question mark configuration, and I can see the pulmonary artery coming out with the Y configuration. I can see everything on a single stick volume acquisition. I can see everything pointing that this baby has got tetralogy fallow. I then look at the neck with slow flow, and when I sweep to the neck with slow flow, I appreciate that there's no thymus gland present. Because when I come up to looking with slow flow, I see the azygous vein, I see the internal thoracics, I can see the subclavian artery vein, but I'm right up against the sternum. There is no brachiocephalic vein, and then the sternum, there's no thymus. So this is a baby with 22q deletion with tetralogy fallow, a call that is made in the first trimester of pregnancy. So, actually I just go to differentials. I'm a little bit over time, I'm sorry. Differential diagnosis is number one, Chẩn fellow, is a common arterial trunk. So you see a vessel that's overriding, but there's no pulmonary artery coming out of the right ventricle. You cannot find one. In fact, the pulmonary artery comes off the trunk and then divides, giving a branch to each side. And this is the truncal vessel that continues around. This is a common arterial trunk. And when you look with color Doppler, a normal four-chamber, VSD, and when you sweep from the left ventricular tract, you can see the branch pulmonary artery coming off and getting off both vessels. This is a common arterial trunk, type 1. So that's the important differential diagnosis. This is a patient to you today who's showing the aorta sitting to the right of the spine, so that's the 14th of May, this morning. And this is the aorta which is sitting to the right of the spine. And when you look at the heart, the apex of the heart is rotation to the left. So I've got two findings in this baby. I've got a left axis deviation and I have a right aortic arch. These are the clues that there's an abnormality. I then see that there's a VSD. I then look at the stick volume acquisition and I can appreciate that the aorta is sitting astride the ventricular septum. So this is a baby who's got a common arterial trunk type 1 in the first trimester of pregnancy. And I've already mentioned about the other types of common arterial trunk. I will say to you one very important message before I finish up. It is very, very important not to make a false positive diagnosis of tetralogy fellow. I have many patients sent to me saying, Simon, tetralogy fellow, I've done the amniocentesis and it's come back normal, and I look at the baby and it's completely normal. Why do you think that happens? Because it's very easy to make a normal baby look like tetralogy fellow if you take an oblique left ventricular outward tract view. Look at this baby. Do you think this baby has tetralogy fellow? No, this baby does not. Because your section which you're taking the LVOT is abnormal. Also, there's no wash of color going across here. This is not a correct, you need to be very careful. You take an oblique LVOT view. And if you're ever suspicious that you think it's valves, go through the motions, look for axis deviation, look for pulse Doppler across the pulmonary valve, compare the two arteries. Be very careful, it's very easy. And also, frequently you will see the pulmonary artery with a Y sign that may look like tetralogy fellow, but this is a false positive. Like all these signs, they're not 100% specific. So just be careful, you can get false positive with these signs. This is it looks like a small pulmonary artery. It's a normal baby with a normal outcome, with a small pulmonary artery, escorted in the great vessels, but nothing else. And we all know that that's a possibility that exists. So I've already spoken about the genetics, and I would say finally that in monitoring babies with tetralogy fellow, we examine them through the pregnancy by looking at the Z scores of the branch pulmonary arteries. We look for reversal of flow in the duct, and we look for the velocities. And we use these to predict outcome, whether these babies are going to require prostaglandins at birth or not. So in summary, 1, diagnosis. 2, exclude other co-truncal abnormalities. 3, offer genetic testing because the association with microdeletions, aneuploidy, and now single gene disorders. 4, follow these babies up with a scan at 28 to 32 weeks, looking for evidence of a severe reduction in the size of the branch pulmonary arteries, reverse of flow, elevated velocities, and the baby is going to need prostaglandin delivery. Segregated into a blue fallows or a pink fallows, and if it's a blue fallows, delivered in a hospital where you know you're going to be able to operate on the baby soon after birth and treatment. Thank you very much for your attention.
Cảm ơn Professor Simon đã cho bài báo cáo rất là chi tiết về sàng lọc cũng như chẩn đoán từ trung khoa lô sử dụng siêu âm. Thì chúng ta chương trình đã hơi bị trễ hơn so với dự định.